wonderful to be here. Thank you for the opportunity. And I have slides prepared. I'm hoping to help provide some examples and solidify some of the concepts that were discussed this morning, but I don't have to get through it all. Feel free to interrupt and ask questions so that I'm not talking at you. So I have no conflicts of interest to disclose. My funding is from NIH, and as you heard, my lens is that as a general internist certified in HIV and addiction and do research at in that intersection. So I like to ground my talks in the story of a patient because we talk a lot about having big public health impact, but ultimately it's individuals that we're trying to help improve the lives of. So this is the story of a patient who I've been taking care of for a number of years now. I've changed the details to protect his privacy. Mateo is a 67-year-old gentleman from Puerto Rico. He first started using heroin at age 16, and he started using consistently in his 30s, injecting up to 4 to 5 bags per day, and had tried multiple inpatient programs and methadone without achieving abstinence. He was diagnosed with HIV in the 1990s and had concurrent hepatitis B infection and hepatitis C. And he left New York City to move to the New Haven area in Connecticut, where we are. In 2000, he was started on buprenorphine, also called Suboxone, which is an opioid agonist treatment, via a large study that Rick and others was involved with to integrate opioid agonist treatment into HIV clinics called the Beehive study. He had remained abstinent from opioids for a long time with that, and his HIV had been consistently well controlled. I met him first in 2013, and he was referred to me for ongoing buprenorphine treatment. And at that time, he also had intermittent heavy episodic alcohol use and daily tobacco use with chronic obstructive pulmonary disease. So I'm going to use his story to illustrate some of the questions and challenges we've tried to address with our research. So first, what is the problem? What are novel strategies to integrate addiction treatment in HIV clinics? And then third, where do we go from here? We can talk about that a little bit. So for purposes of my talk and time with you, I'll talk briefly about what's the problem we're trying to address and just share some basic definitions. I'm going to share with you different aspects of 3 different clinical trials I've had the opportunity to be involved with, and we can talk more about current directions and current and future directions. So just to make sure we're all on the same page when thinking about definitions for substance use, this is the pyramid of thinking about the spectrum of unhealthy substance use with lower risk or no use at the bottom of the pyramid, right, which is the most common form of use. At-risk use, which is, with impacts many, but not as, it doesn't have as severe consequences. And then you see here the definitions, what's typically used for at-risk or risky alcohol use, and then drug use. So we think about any drug use as being at risk, and risky or at-risk use, you can see the definitions here for men and women. And then at the top of the pyramid is what we think of those with substance use disorder, where they have manifestations of loss of control, ongoing use despite adverse consequences, and craving. And when I refer to unhealthy substance use, I'm thinking about these 2 categories, okay? So just want to make sure everyone has that clear. So we know, I'm not going to belabor this, we know that there's a major global burden of disease attributable to alcohol and drug use that's significant. Here's our global map, looking at alcohol use on the top and then drug use on the bottom. I'm not going to belabor that for this audience today. And unfortunately, we know there's also a large unmet need for substance use disorder treatment among individuals over 12 years old. So these are data from the National Survey on Drug Use and Health, which is a large national survey conducted in the US that shows by age group the percent of individuals who needed treatment in the past year, and then those who actually received it. And so here you can see the different age categories on the x-axis, and then here is the percent needing treatment, and then the percent who needed treatment and received it. And you can see there's a major gap, right? We have lots of evidence-based treatments and people aren't getting it. So that's where we are in the space of implementation science. Among individuals with HIV, this is a major concern. So individuals with HIV, just thinking about different substances, opioids, patients with HIV are more likely to overdose. When we look at different HIV care metrics, this is individuals engaged in HIV medical care, treated with antiretroviral therapy and virally suppressed. As you increase levels of alcohol use, right? So that's increasing levels of alcohol use across here by each category. You can see that patients are less likely to meet each of those really important care metrics across the HIV care continuum. And then lastly, just thinking about tobacco use, I'm going to focus on these 3 substances today. So this is why. When we think about patients with HIV, those who are receiving HIV treatment with antiretroviral therapy lose more years of life because of smoking than they do to treated HIV. 8 years loss of life due to tobacco use. So really important that we're addressing that for patients. And as we've heard about and discussed today, we know that integrated care models with opioid use has demonstrated it's really effective to bring opioid agonist treatment into medical care settings where patients are showing up anyway. And so we've built on that premise with some of the work I'm going to talk about now. So this is kind of the background. So with that background, we wanted to think about how can we better integrate addiction treatment in HIV and HIV care. And thinking about Matteo, again, he did really well with the buprenorphine. It's been a non-issue for him. He's done extraordinarily well. But we wanted to think about what can we do for him for his alcohol and opioid use that were still ongoing problems for him. So when we think about this kind of buckets of treatment options to address unhealthy alcohol use, again, at-risk alcohol use disorder, in an HIV clinical setting, we have medications. The 3 medications that are approved by the Food and Drug Administration in the US to address alcohol use are acamprosate, disulfiram, and naltrexone. And then we also have behavioral interventions, right? As listed here are some examples. So we want to think about how can we bring these to the HIV care setting. Data from our group and others demonstrated that naltrexone, the injectable formulation, was safe in the context of HIV and efficacious. There had been some concerns about the antiretroviral interactions. And so this was some work in that efficacy space, right? When we think about the research pipeline. And so then we wanted to move down thinking about, as we had those data, how do we move the needle and package some of these interventions, the injectable naltrexone, the other treatment options with behavioral interventions for patients with HIV. Am I going too fast? Okay, I'm keeping folks awake after lunch. Okay. And so with that in mind, we thought about how can we, again, bring behavioral interventions with medications in a treatment setting where HIV clinicians aren't prepared to address substance use. They have the time constraints, all these things that we've heard about, right? And so we turned to step care models, which is a type of adaptive intervention. And Denise talked about this morning, where you have a flexible and responsive approach to patient needs, especially when a one-size-fits-all approach is not relevant. You have increasing intensity of services for individuals who are unable to reach pre-specified treatment goals. And it's been previously applied to common conditions. We do this for hypertension, depression, pain, right, where we increase the interventions if people are not getting better. But it hadn't been done too much in the context of alcohol use. One thing that's really important is it minimizes demands on patients when there's particularly patients who are not coming in for treatment. Patients who are coming to HIV clinics, they're not necessarily asking for help for their alcohol use, right? They don't necessarily think it's a problem. No one's talked to them about it being a problem. It's normative, right? It also maximizes use of clinic resources while incorporating different evidence-based practices. So that's the key, right? You're taking evidence-based practices and figuring out a model to deliver it together. Again, feel free to interrupt me. I don't have to talk at anybody. So we moved thinking about the data for naltrexone. I didn't get into that, but just trust me with those papers, right? We had efficacy data that we can bring injectable naltrexone and these other medications in the HIV setting. We were now in the effectiveness space. How do we create a model of care? And so what we did is what we called the starting ethanol treatment in primary care trials, or STEP trials, which were 3 parallel randomized clinical trials with the goal of evaluating the effectiveness of integrated stepped alcohol treatment for unhealthy alcohol use versus treatment as usual for patients with HIV, and 3 separate categories. If you think about that base of that pyramid, they had moderate alcohol use, but they had liver disease, so they really shouldn't be drinking anything at all, right? If you have cirrhosis, you don't want to be drinking any alcohol. Those in the middle of that pyramid with risk alcohol use, and then the top of that pyramid with alcohol use disorder. We did this in 5 VA, or Veterans Affairs based HIV infectious disease clinics across the United States. For purposes of today's talk, I'm going to focus on the alcohol use disorder findings, but I've listed here a number of our papers from these trials if there's interest in looking at that. So the model of care differed a little bit depending on what level of alcohol use a patient had. But for those with alcohol use disorder, we started them off by seeing with an addiction psychiatrist in an HIV clinic. They started off with recommendations focusing on provision of starting addiction medications for the alcohol use and brief counseling. So it was a medical management model. At week 4, they were evaluated to see if they had ongoing heavy alcohol use in the prior 14 days. And they were stepped up or advanced for a higher level of services if they had not, if they had any evidence of heavy alcohol use. And they were asked to see a psychologist for motivational enhancement therapy over a number of sessions. At week 12, they were then also evaluated again, those folks who had been advanced to step 2 with the psychologist for specialty referral to receive detoxification, intensive outpatient program, whatever was locally available at that VA. We compared this to treatment as usual, which was a referral at the discretion of the HIV provider they were seeing for specialty services. One thing to just know about this treatment setting and within the VA health system in the US is that there are a lot of services available to address addiction, and there is access to addiction specialty care within the sites where patients are receiving care. So these were the baseline participants of the baseline characteristics of the enrolled participants. We enrolled 128. I'm blanking this minute what the target was. I think it was 160. So we did not meet recruitment targets. I'm sorry, I'm blanking on that specific number, but this again was, we did not recruit per target. Consistent with it being a veteran population receiving HIV care, it was largely male, almost exclusively male, middle age, predominantly Black. And you can see they had significant levels of alcohol use. The Audit C is a screening tool, 3-item screening tool for alcohol use. And these are consistent with higher scores, consistent with having an alcohol use disorder that ended up getting confirmed with an assessment. You can see significant drinks per week of 30, over 30 drinks per week on average. 30+% had a detectable viral load, and they had robust CD4 counts. And so the first question we asked is, when we look at the results, is how often did we actually have to step people up? How often did, we should dance, individuals not have, were unable to meet that goal of not having heavy alcohol use at week, in the prior 2 weeks at week 4, and over half needed additional services. So 52% had ongoing heavy alcohol use at week 4 and were stepped up to see the psychologist. And then among those, that's why you see the denominator shift, right? Among those who were stepped up at week 4, 57% were advanced to step 3 and referred for specialty services. Does that make sense? And then we ask, okay, what about the individual visits? So in the blue here these are the addiction physician management visits over the 24-week period that started out being weekly for the first few weeks, then bi-weekly, and then monthly. And you can see, in the beginning, folks are showing up, and then there's significant drop-off over this 24-week period. So even, regardless of whether or not they were stepped up, they were invited to see the addiction psychiatrist. Here at step 2, you can see that not everyone walked in the door to see the psychologist for motivational enhancement therapy, but what you can see here, between 23% and 37% showed up for those visits. One thing that I should point out here is consistent with being an effectiveness study, neither the patients nor the providers were paid for these visits or attendance at these visits. So there was no incentive for participants to show up. These were offered. We asked them to come, right, as part of the protocol, but there was no requirements that they had to come, right? So just to keep that in mind. And quite honestly, this is not that different than what you'll see in primary care for alcohol use. Patients often kind of drop off. So we were excited to see that there was higher levels of engagement than what you would see typically. So then here, this is looking at some of our process outcome data, looking at receipt of medications for alcohol use disorder. And what you can see, this is by the FDA-approved medications, disulfiram, acamprosate, and naltrexone. This includes injectable and oral formulations grouped together. And then at baseline, week 24 and week 52, this is looking at, did they have evidence of receipt of this medication by pharmacy refill data at each of those time points in that 6 months prior to that window. So for example, week 24 is, in the 6 months from baseline to week 24, did they receive any medication? And what you can see is those who were randomized to the treatment arm, there was a few got disulfiram, a few got acamprosate, and there was significant increase in both the acamprosate and naltrexone provision compared to treatment as usual arm. And again, evidence-based treatment, people are more likely to get it by being enrolled in this study. And then looking at primary outcome data, when we looked at drinks, let me orient you to this, these busy figures. If you focus first on the left, on drinks per week, this is looking at the integrated stepped alcohol treatment arm in red and the treatment as usual arm in blue. So everyone decreased their alcohol use, right? Like maybe you call that regression to the mean, Denise, I don't know. And we did not see a statistically significant difference at week 24 or week 52 for drinks per week by group, but you can see that the adjusted mean difference indicated that among those randomized to the integrated step care arm, they were on average drinking 4 drinks less per week at week 24, almost 7 drinks less per week at week 52, not statistically significantly different in our trial that didn't meet recruitment targets. And then here, when we look at proportion with no heavy drinking days, again, this is integrated step care arm in red, treatment as usual in blue. We saw no difference at the week 24 by group, but at week 52, there was a 5-fold increased odds of individuals having no heavy drinking days at week 52. I don't show it here, but one of the exciting findings in our secondary outcomes was that we saw increased proportion of viral load suppression at week 52 as well. And so we were excited that in an accompanying editorial that was written by members of NIH, they highlighted that the study is of great importance to the field for HIV and beyond because it addresses the current need to improve the way alcohol use disorders in general and in the context, in the context of HIV and in general. So again, time to bring addiction treatment into primary care settings, right? And so that was exciting. And it was highlighted as well in the, this idea that we should be integrating treatment in the HIV/AIDS treatment guidelines that are kind of the national standard for care. So again, helping move the needle, we should getting patients wherever they're showing up evidence-based treatments. And we all know that in the room, but it's exciting that that message is being conveyed. So that was the STEP trials. We have gone on since that time to build on those lessons. And what we learned was from those trials that there's support for an integrated STEP care model in HIV clinical settings or increasing provision of evidence-based treatments to patients. We're seeing signal that it's helping reduce alcohol use, improving HIV viral suppression, and just a model of care to get patients treatments that we know work, right? We also saw, given, you know, as you looked at the figure where we saw visit attendance, right? Visit attendance had room for improvement. We didn't recruit those, the number that we wanted to. And so we thought there was low patient motivation to address alcohol use, stay engaged in the trial and enter a trial and stay engaged. And so we have now finished a trial where what we called the first trial, where we added incentives with contingency management to an integrated step care model to address this. And those findings are under review right now. So I'm gonna circle back now. So we went from efficacy work, right? Effectiveness work. And we kind of took, even though we know we have room to improve how we're doing, we wanted to take some of the evidence-based practices that we know exist and move them into the, work on implementation. So I'm going to move there next. So just to make sure everyone's on the same page when thinking about treatments for tobacco, alcohol, and opioid use, right? We have a number of medications for each of these conditions that I understand are also available here. Some with higher levels of cost, but potentially accessible to individuals. And then also counseling interventions for each of these conditions. we focused on these conditions as it relates to addiction because things like stimulant use disorder, we don't yet have a great medication option, right? But these are things we can be doing in primary care and HIV care settings. And so we turned to the implementation strategy we selected for this work, and I think I'll talk about this more later in the conference, is implementation facilitation, which is a large bundle of strategies, right? This is a big bundle, bit of a kitchen sink, right? To help move the needle and implement evidence-based practices. And there was a nice review that informed the selection that shows that primary care practices, when they're exposed to implementation facilitation, are almost three times more likely to adopt evidence-based guidelines through implementation facilitation. So we use that approach to help move the needle on addiction treatment. The goals of what we call the Working with HIV Clinics to Adopt Addiction Treatment Using Implementation Facilitation, or What If, were to use mixed methods to identify barriers and facilitators to the integration of addiction treatment to inform the implementation facilitation strategy, and then to assess the impact of this on a number of implementation outcomes, right? So this is, I'm hoping to bring together by example some of the things we talked about this morning. So this was conducted from July 2016 through July 2020. This was a randomized clinical trial using a hybrid type 3 implementation effectiveness design to evaluate the impact of implementation facilitation on implementation and effectiveness outcomes. So just to harken back to what you heard this morning, this is on when we think about the hybrid design pipeline, right? Hybrid type 1 really focuses on effectiveness outcomes. Type 2 focuses on implementation and effectiveness outcomes equally, and type 3 really focuses more on implementation outcomes. So that's what this was. It was conducted in 4 HIV clinics in the US Northeast. One thing we heard about this morning is sometimes things happen as you expect and sometimes they don't. One of our 4 sites was rolling out their electronic medical record during the context of the study. So we assigned them to be the last site because of data collection needs, and we randomized 3 of those 4 sites to the timing of when they were going to start receiving the intervention. And this was consistent with a stepped wedge design, Denise's favorite, where we had to collect data from, we were using provider level outcomes and then EHR data. So we did provider surveys. I think we had 7 rounds of provider surveys. I will never do that again. We learned not to do that. But you can see here, everyone has a control phase. They sequentially and randomly roll over into the intervention phase where they receive the implementation facilitation. And then you have a period of evaluation and maintenance. And the maintenance phase, the evaluation phase, as I hope you can see, follows right after the intervention period. And then you're looking to see what is the durability of the intervention after that evaluation period. And COVID happened, let's see, I think like right here. So for some, I won't go into this too much, but I wanted to use the opportunity to introduce a different implementation science framework that's that's another determinant framework that I like, in addition to CFR, is Paris. And there's an updated version now called iParis that focuses on the recipients of the intervention. But I find this to be really intuitive and pretty easy to wrap my head around, where you're thinking about perspectives on the intervention, perspectives on the context, and then the facilitation or helping needs. And so just to share some of the results with you from these surveys. So at baseline, we asked about readiness to prescribe or refer for medications for addiction treatment by substance use disorder. This was among the clinicians and staff at the 4 sites. So that was 71 individuals who responded. And you can see when looking at different substances, there was varying levels of willingness to take that on as a problem and readiness to do that. And not surprisingly, so the majority were ready to address tobacco use. It's pretty split for alcohol use and somewhere in the middle for opioid use disorder. So some clinics already had processes that were pretty robustly in place with a specialist on site and the like for opioid use disorder, which was interesting. This is one of my favorite questions to ask. We've done this around PrEP as well as for addiction treatment, because I think it's really relevant for thinking about implementation work, is what is going to be, how are you going to like design a program? Are you going to train everybody up to address your problem? So we asked, in your opinion, which approach do you think would be most feasible to improve treatment for opioid, alcohol, and tobacco use disorder? We asked that for each item, but you can ask that for, is it Hep C treatment? Is it, pain, whatever it is you want to take on. If you want to have a diabetes specialist in a particular context, depending on the resources and people's comfort, you can ask that question and think about what's going to help move the needle in that specific setting. And what you can see when we asked about, everyone getting trained up, you have a designated on-site specialist, and no one here can do it. We got to bring somebody in to do it. Or, hey, we don't want to deal with it here in this place, right? You got to send them out. You can see what we found for tobacco use disorder, alcohol use disorder, and opioid use disorder. And this was, again, at baseline. Again, not even half wanted to take on tobacco use, which is, it's a pretty important problem. I won't go into too much here, but just to share that we had done qualitative work throughout this study, and with asking, informed by the Paris framework around tobacco use, perspectives on tobacco use, alcohol, and opioid use disorder treatment, just to focus on the tobacco use because it informed our next trial. We heard about, facilitators were that everyone recognized as a major threat to health, and they had really liked it when there had been dedicated staff in the clinic to help address it. However, unlike, I think not surprisingly, it was deprioritized relative to other health issues. There is variable patient motivation to address it, right? And treatment response, right? We don't necessarily have a magic bullet. And there was concern about pills side effects. And also we did hear about patients prefer, that shouldn't be under, I guess that should be over here. Patients preferred patches, nicotine replacement therapy. And so thinking about preferences, that was something that was important for us to keep in mind. This was our primary outcome from this work, where we, again, focusing, here's tobacco, alcohol, and opioid use. I'm going to focus on tobacco use for this presentation. And what this is looking at how did the implementation facilitation impact provision of medications for those who were treatment eligible. And what you can see is that over the intervention, evaluation, and maintenance phases, we increased the likelihood or the odds of provision of treatment across those periods. So here's an odds ratio for the intervention phase of 1.40, 40%. People are 40% more likely to have had a 40% increased odds of receiving treatment with the intervention. But when you look at the numbers here, it's disappointing to see that over about 60% of patients who had a diagnosis of tobacco use still were not getting treatment. So there's we move the needle, but still lots of opportunity. We also saw, this is looking at how did we do in moving the needle in terms of preferred models of care, where we looked at preferences for on-site resources, where they either train people up or had a designated on-site specialist. And we saw, again, with the intervention, when we looked at tobacco, alcohol, and opioid use disorder, you can see that there was increased preferences for an on-site model, which, again, moving the needle that way so that people were starting to take on that problem. But as we work to move in how we were addressing tobacco use with this trial, we learned, again, more opportunities. So we cycle back, right? And so it's all iterative, as you're hearing, right? So we use those findings to launch another trial called A Smart Approach to Treating Tobacco Use Disorder in Persons with HIV. And this is a smart design that I'll share with you. We used incentives here with contingency management, which is a very strongly evidence-based practice to address substance use and other health behaviors. Who here has heard of contingency management? Awesome, so a few hands. It's the use of tangible and timely incentives for achievement of verifiable behaviors. The goals are to motivate behavior change, especially for behaviors that are likely to have greater future than present reward, to offset discounting of delayed reward. So people like to feel good today and right now. So it's to help people feel good right now to change their behavior for something that they'll feel the benefits later on. It's beneficial in decreasing substance use, including tobacco use, improving HIV outcomes. And it built this study built on our experience using it to address alcohol and tobacco use in HIV treatment settings. We designed a trial that prioritized nicotine replacement therapy over varenicline because we had heard in some of the focus group data that patients and also providers had concerns about interactions with varenicline. And so they really wanted to think about nicotine replacement therapy. And there had been limited prior studies that had compared the efficacy of NRT or to varenicline to guide prioritization of one treatment over another. And no studies had yet studied the switch from one treatment to another. We included clinical pharmacists as part of the treatment team to offset the burden on the HIV providers whose behavior is really hard to change, right? And we know that integrated care models work best. We know interdisciplinary teams are the norm in HIV clinical settings. And we know also that clinical pharmacist involvement as part of an HIV care team improves HIV-related outcomes. And additionally, clinical pharmacists were more, increasingly involved in addressing tobacco use in community-based pharmacies and also in other health systems. And so then we asked, how do we create an adaptive and scalable intervention? We use the SMART design approach with the sequential multiple assignment randomized trial design. I'll show you how we put that together. And it promotes tailoring of intervention based on a patient's response, as you heard from Denise this morning. It allows for determination of the optimal strategy to reach your target outcome, as well as evaluating intervention components. We did this with a hybrid implementation effectiveness type 1 design. We grounded this in Paris and the RE-AIM framework, and we'll be eliciting perspectives of clinician and staff pre and post trial. I will share with you what our revised aims look like, because I'll share some of the challenges we addressed along the way later on. But for today's purposes, our goals were among 320 patients with HIV who smoke tobacco, who are receiving care in one of 3 health systems, to identify the optimal adaptive intervention to promote smoking reduction, to evaluate its impact on HIV outcomes, and then to conduct an implementation-focused process evaluation. This is our protocol, where we randomize individuals with HIV who smoke, who are not actively receiving treatment. They get nicotine replacement therapy with counseling by the clinical pharmacists in the HIV clinics. The other half, in a one-to-one randomization, also get contingency management. If they respond, they continue on that arm. If they don't respond, they get re-randomized to either intensify their contingency management or to switch to varenicline or bupropion, which are the other tobacco treatment medication options. We assess their outcomes at week 24, which include smoking status and HIV-related outcomes. And at week 12, we tailor their response to based on whether or not, we tailor their treatment based on their response to whether or not they've smoked even a puff in the last 7 days. So that is really what guided whether or not we were going to re-randomize them or not. These are the components of the intervention that I hope are clear from what I discussed. And just to, this is the book that guided and Nancy Petrie's teachings that guided our design, where we used a fishbowl prize system. So individuals earn draws from this fishbowl. It resets if they're self-reported tobacco, if they had self-reported tobacco use, or if they were unable to confirm abstinence, or if they had an unexcused absence. And they had 5 potential visits over each of the 12 weeks of the study. And this is really what's interesting about the challenge of bringing contingency management to HIV clinics is, unlike some specialty treatment settings, patients are not coming in as often. Sometimes they're coming in once every 6 months for treatment. And so for something like smoking, you'd ideally be verifying their tobacco use every day, multiple times a day, to help guide the rewards program. So we had to balance that, and we landed with 5 visits over the 12-week period. We have now finished recruitment. We are in data collection period, and we enrolled 323 participants. We'll have data on outcomes in a few months. We don't have them yet. But I want to share with you some of the work that we had done, guided again by the Paris framework, to assess qualitatively perspectives on the intervention that we had put together. And this work is under review currently. And just a shout out to some of our team members here. And we, our findings really center around the evidence for the intervention, what the context was like, and what the needs were to try to improve this as next steps. And I'll just give you a couple of example quotes. So one clinical pharmacist said, and also one of the things I like about meeting the patient in clinic is kind of explaining to them and showing them that this study is very well integrated into their doctor's office and that is a cohesive part of their care. A participant said, the clinical pharmacists know that talking about, and they know what they're doing. They're not wishy-washy. She was, if I had a question, they had an answer. If not, they were willing to look it up. So again, this idea of bringing the clinical pharmacist into the treatment model was something that was novel in this context and well received by participants. And then with regards to the contingency management, one of the participants said, it was difficult because I want to smoke in between, but I know if I smoked in between that it would tell on me, and that's the smokalizer. They were responding to, blowing in to see if they had carbon monoxide. So I did. So I white knuckled it not to get a chance to pull a $100 gift card out, a $50 gift card out, 25, 5. It didn't matter how much. I knew I was going to do with it. I knew what I was buying. I wasn't using it to buy cigarettes. I knew I was using it to help maintain my household. So to me, this was a pretty powerful quote by this participant. So we'll have findings in a few months. I'd be happy to share that when we have it. But just to kind of circle back, I hope I've helped share with you some of the ways in which we've used different implementation science design, hybrid designs and different trial designs, step care models, smart trial designs to start to address some of these questions and use implementation facilitation. In terms of current and future directions, just to go back to Matteo, fast forward to 2023, his HIV continues to be well controlled. He's been abstinent from opioids on low dose buprenorphine. He takes 2 milligrams a day and has done really well and wants to stay there. He's decreased his alcohol use. He's stopped smoking with dual nicotine replacement therapy. Now the challenge for him is his obesity, his metabolic syndrome, and so we're working on those things together. But that's a success of his treatment for his substance use and his HIV. So in summary, and next steps, implementation science principles that we hope you'll all be convinced and then go running with these new tools after these next few days to guide your efforts to improve adoption of what we know works. We also know there's an ongoing need to cycle between efficacy, effectiveness, and implementation science designs, right? We move the needle, we don't get the magic bullet yet. We try to make it even better each time. And new efforts can be directly informed by mixed methods to inform the tailoring of the intervention strategy to stakeholders and the contextual needs. And then I would last say with successive HIV and addiction treatment, there's a growing need to enhance primary and secondary prevention of medical comorbidities. So that's our next challenge. Lots of people that have contributed to this work I want to acknowledge, and really big thanks to the group here and the organizers. I'm happy to take questions.
Thank you so much for this very rich presentation, for the series of studies with the smart titles, and also that you grounded everything in the case of Matteo. So it was very helpful. So we have a few minutes for questions. Please shoot it.
Therapies are heard and incorporated in the study design?
So I think, I guess it depends on the different study. For the smoking study, the SMART trial, what was really exciting for us was we had done the work in the context of the implementation study. And so had focus group, I'm sorry, I probably didn't explain that well, but we had done focus groups with patients who were receiving clinic care in the HIV clinics, as well as providers that helped inform exactly the design of the intervention we used in the tobacco treatment trials. I think we also, in terms of the implementation work, we fed back to the clinic leadership the findings that we had from those focus groups as we were thinking about how can we best move the needle to impact addiction treatment. I don't know if that helps.
Yes, please.
Such a great presentation, Dr. Edelman. Your approach. I was curious how you decided on the order of operations, like, you know, what are the yeah. So for this trial, those with alcohol use disorder, we started off with them seeing an addiction physician with the idea that maybe if we can get them stabilized with some, you know, kind of help decrease their cravings with alcohol use with the medications and prioritize that, then maybe they'd be in a better position to engage with behavioral interventions and counseling thereafter. And so that was the approach we took there. And then for those who had at-risk drinking or moderate alcohol use in the context of liver disease, they start off with seeing a social worker for a brief intervention and a telephone booster. If they didn't respond, then they saw a psychologist for motivational enhancement therapy. And then if they didn't respond, then the step 3 was to see a psychiatrist. Thanks for asking. And, you know, I should say, you know, everything that we do in the clinical trial context is intended to supplement whatever services people want to get anyway. And so we measured that. But if they had wanted to see a psychologist upfront, then surely they could, right? And so nothing gets in, we don't ever want study participation to get in the way of other things.
So Jen, my question is about the what if trial where you decided to measure your outcomes at multiple different time points. I think you measured it during the intervention. You had an evaluation phase and then you also had a maintenance phase. I thought that was really interesting because so often I think when you implement something, you don't know when it's going to be kind of optimally taken up or sustained. Just wanted to hear a little bit about how you thought about picking those time points and if there was any signal. It seems like there were some differences, but just how it worked out in terms of your interpretation of using that approach of measuring outcomes at multiple different time points.
Thanks, Luke. I can go back here. Right, so here's the stepped wedge. So I think it's pretty typical with a stepped wedge design that after the intervention phase, I'm curious as to others have done other stepped wedge designs to look at the impact of the intervention right after the intervention and then also for maintenance. And so that's what we did. You know, there's for the group that was randomized last to the intervention, there's only one maintenance window there, right? So the periods differ depending on the timing of the randomization. But the idea was to see, you know, changing practice takes a long time, right? And so the idea was if you do some intensive intervention, and I didn't get too much into the detail of what we did for each of the sites, but we basically started out, we worked intensely with each site when they were in the intervention period, and then invited all sites as they had kind of been activated to participate in a learning collaborative. And so the idea and hope was that you'd start this activity and then it would continue. Did that answer your question? Yes. Okay.
Thank you. Really nice presentation. From the viewpoint of practicality, You mentioned that you are not going to repeat this survey with
yeah.
service providers. So what was the pitfall?
Oh, so
should
I would just say,
expect.
I would never try to do 7 waves of primary data collection with providers. That was
Okay,
the,
that's
that,
7
thank you.
waves.
We did, because for each of, right, that was, as Denise had kind of warned us, right? So with the stepped wedge design, you have to collect, I think what's key if you're going to use a stepped wedge design is that the outcomes that you're measuring are data that already exist. So they're electronic health record data or some other way you're going to get it. So here for our study, and I'm sorry, maybe I didn't spend enough time on it, it was electronic medical record data for the medications, but for the provider perspectives, it was, I think it was 7 waves. It was like baseline, and then at each period, we were surveying the providers. So it took a lot of love to get those responses back, right? And so that's what I wouldn't do. I think if you're gonna survey providers, you want to do it maybe, I don't know, twice at most, not, this many times. I think it's hard to do that. Or you just have to be prepared to do it if you're going to do, those kinds of outcomes. That was the part I was referring.
I
So
understand.
thanks
you
for the opportunity to
absolutely.
clarify.
Because we had this relatively the same experience, and
Yeah.
I thought maybe that's the different issue. I need to know in advance or
Yeah,
something like
I
that.
think if you want to do stepped wedge, you want to make sure you have, I would suggest to the extent possible, having ways to collect the data that are not dependent on, individual responses at multiple periods in that way. That was my caution. Sorry, thanks for the opportunity. to
Thank
clarify.
you.